The team at Rooks County Health Center in Plainville show us how occupational therapists help patients regain their independence.
My name is Jessie Teen, and I am an occupational therapist and a certified hand therapist at Rooks County Health Center in Plainville, Kansas. I have been an occupational therapist for a little over 4 years and a newly certified hand therapist. So I come into work and I have a set outpatient schedule where there are patients that are scheduled to arrive on time for their outpatient appointments. And then in between those patients, we will go down the hall and see the acute or swing bed inpatients that are here and staying in the hospital.
Hi, my name is Amy Carlin. I am a certified occupational therapy assistant at Rooks County Health Center. I have been a CODA for about 24 years. I graduated in 2000 and took my boards in 2001, I believe. I went to school at North Central Texas College in Texas, where I'm from. I had the advantage of being in an advanced healthcare class, which meant we got to pick 6 healthcare professionals that we were interested in, and we got to follow them around for a semester. Occupational therapy was one of them, and it's the one I fell in love with the most. So I've gotten to do so many different areas. My favorites is pediatrics, which we get to see here a lot, and then adults with developmental delays. We get variety and you can choose anywhere, but here at Rooks County Health, we get to see everything because we are a rural provider. So there's not as many options for them to go. So we get to see everything, but that means you also get to see some of the hard ones and then some of the super fun ones. So here at Rooks County Health, it can be anything. I have inpatients and outpatients that we see. So I can go in, I'll spend about half the day with our inpatient clients working on return home. And then a lot of the day is also spent in outpatient where I have both rehab and pediatric clients.
So we treat a little bit of everything at Rooks County, being a rural critical access hospital. I specialize in outpatient orthopedics, so being a certified hand therapist, I treat hand to shoulder girdle outpatient injuries. This can include tendon repairs, nerve injuries, strokes, a wide variety of conditions. But we also offer inpatient services, so we see acute and swing bed inpatients, as well as pediatrics and various other injuries and conditions. I enjoy helping patients work towards whatever individualized goals that they have, and it looks so different on each person. My job is to help people get back to whatever activity that they find meaningful to them in regaining independence. And if they are unable to do an activity the way that they did prior, then helping them problem solve new ways to do it to where they can still maintain their independence. I obtained my bachelor's degree from the University of Kansas, and then I went to occupational therapy school at Rockhurst University in Kansas City, Missouri. Bachelor's degree for 4 years, and then occupational therapy is a postgraduate degree, so either a 2 or 3 year master's or doctorate program. So I did a 2-year fast track master's program, so all in total 6 years. Post-graduation, I did a 1-year fellowship in hand to shoulder therapy, and then I took another board exam after that for my CHT. So there is often a lot of overlap between the two professions. I often get called a physical therapist because we also do perform, range of motion, strength assessment, a lot of interventions such as that. However, the basis of occupational therapy is function and improving someone's ability to participate in their everyday activities, what's most meaningful to them. And so even if we are treating, a hand or a shoulder patient that has a tendon repair, the exercises might look very similar or identical to what a physical therapist would perform. However, we're often adding in the fun things such as what Amy talked about earlier. We're being functional. We're trying to find things that they can do in everyday movement, such as I'm going to have you actively grasp and release objects. I'm going to have you pick up pennies and put them in a container rather than just, okay, open and close your hand several times. And so that's really the basis of OT is function.
I'm going to piggyback on that also is because OT will have more adaptive equipment or different changes to a routine that the physical therapist may not come up with. So for an arthritic patient, being able to grasp it and turn it may be hard. Okay, well, here's several different things to try to see if that helps. And so we take that functional approach more than just what is your strength or what is your range of motion.
Yeah, so another way to word that would be if we're unable to, fix or change their injury or disability, then we're trying to modify the environment or help them find ways that they can do things differently to where they can still accomplish those goals.
I want to welcome our panel of experts to answer questions about the career opportunities you have working in occupational therapy. Joining us this morning from Rooks County Health Center are Jessie Teen and Amy Carlin. Good morning.
Good morning.
Well, so good to see you guys this morning. I'm going to have questions for each of you, and then we're going to be able to go to the chat. So we're reminding folks to put their questions there. But my first question, I was hoping you guys could describe a challenging case you've worked on and how you've helped the patient overcome their obstacles. Let's start with Amy.
So the little girl you saw in the video, she had a really hard time being around people of her own age. She can do things with adults or teenagers. So one of the things we did was had a kid come into the clinic with us and they played separate for a while. And we just encouraged her to get closer and closer until they could play together so that she could be successful in preschool.
Great. How about you, Jessie?
Yes, I think something, I'll give an orthopedic example, is that patients often have multiple comorbidities, and so it's not just a clear-cut diagnosis. So for example, I had a patient that was sent to me with frozen shoulder, but he also recently had open heart surgery. So the typical course of treatment for that is kind of more aggressive joint mobilization and stretching techniques, but I had to really take into consideration these other precautions that this patient had and have close communication with the physicians in order to progress according to his needs.
Good examples. What about the work-life balance? For a hospital occupational therapist, we're wondering, are there shifts, and what are your shifts typically like? Are they 8 to 5, or what kind of shifts do you have? Or are you working nights and weekends?
We have weekends off here, which is nice. Working at a rural critical access hospital, they are more accommodating and flexible with our schedule. There is only 2 of us here, so we have to be well-rounded and provide services for both inpatient and outpatients. But what that looks like for full-time for me is I work 4 10-hour days. Sometimes that does drag on a little bit longer if we get, an inpatient admission at the end of the day, for example. But there is flexibility with that schedule, and I do have longer weekends, which is nice.
And then for me, I work 5 days a week, but I work 7 o'clock to 3 o'clock, and then I can go home and be with my family.
Wow. Well, that's great that there's some flexibility. Do you feel like when you talk to colleagues in urban areas, is that kind of the case for all OTs, or is it just because you have a great employer?
So we have a great employer.
We have a great employer. I will say life balance here is a little bit different than some of the other professions or practice areas that I've been in. I'm from Dallas, obviously much bigger than the rural area here. And sometimes it was harder because the expectation is to work 40, 50, 60 hours. So
I would say depending on the setting, just as similar to what Amy had said, I have a little bit of experience working at an inpatient rehab hospital, and there those patients have to get therapy 7 days a week, and so you are on a rotating weekend schedule. So we have a lot of privileges out here that aren't always seen in typical settings.
That's great. Well, thank you for all that insight, Jaren. I am sure we've got a lot of folks chatting questions right now through the Zoom chat. So I'm going to turn it over to you to see what kind of questions we have.
Yeah, you bet. Thanks, Cindy, and good morning. One question we'll start with for you both. How difficult is your college educational experience, coursework wise, but then also the training side for both when you're in occupational therapy school and then also occupational therapy assistant school? And Amy, maybe if you want to take the first stab, I'll let you take it away.
perfect. Getting into school was difficult, but once it was there, it's a lot of fun. The coursework is not excessively difficult, but it's a lot of fun, a lot of hands-on, and a lot of internship training. So I felt prepared once I got out to just keep working.
And then I would say on the occupational therapy side, obviously applying to any graduate school is a very stressful experience. And so similar to that it is a very rigorous program. It is now a master's or doctorate level program for occupational therapy. But it's absolutely doable. You have the support of your classmates. Everybody is going through all of that together. And then we end on, at least my program ended on 6 months of clinical experience. And so they make sure that you are prepared for that transition into the clinic. It isn't just school and then you're kind of out to fend for yourself. And so it is nice that you feel prepared with the internship and the clinical transition experiences.
Thank you. The next question, Jesse, if you want to start with this one, could you speak a little bit more on what might be some of the scope differences, role differences between what an occupational therapist can do compared to where does the line draw with the CODA?
Yes, so I perform the initial evaluative process. So I go in and I see the patient, I check on their range of motion, their strength. I get really all of that background information about their function and their goals. And then there's a lot of documentation that is also comprised of that. So I write that evaluation and then Amy will see that, see what the goal areas are. And then she has complete flexibility and freedom to address those areas with whatever skill set and interventions she chooses to do. And then I also follow along for progress note and then discharging patients. So.
Amy, anything else?
So I think Jesse and I work great together because our backgrounds are a little bit different. And so the areas that I'm stronger in, obviously I can assist with a little bit more, but then I also have her to lean on and ask any questions or help us find the right answer.
Mm-hmm. Yeah, we're able to kind of broaden our caseload and the services we offer in that aspect because Amy's strengths are pediatrics and mine's orthopedics. And so I'll evaluate a pediatric patient and honestly, I'll be upfront with Amy of these are the deficit areas, go for it, do whatever you feel like you need in order to work on that. And then I have full trust in, that Amy's going to do that to her best ability.
Sounds like a great example of the healthcare team that's necessary across a lot of departments, but especially here in occupational therapy. Well, another question, we've talked a lot about positive things both in this segment and throughout the day, but what are maybe some challenges that you all work through with occupational therapy, whether that's patient related or maybe other things that go unseen that are not always at the forefront of what folks think of when they might hear or think about an occupational therapist. Amy, if you want to start that out.
Sure. So some of the difficulties that we have is if a patient and a patient's family aren't on board together. So that can be difficult as we're coming up with treatment plans. For pediatrics, very much so, but also for some of our adult population who cannot return back to their prior level of function. And then that in general is difficult. It's really hard when they don't make the progress that they want and they don't recover to the point that they expect to.
Yeah, I'll just sample onto that. So inpatient is a great example of that, as you have a patient that comes from home and presents to the hospital with some sort of diagnosis and, family has one opinion of how they're doing, patient has an opinion of how they're doing. therapists have a different opinion of how everybody's doing. And so trying to align all those perspectives and getting the patient and the family, to see things from the physician and the therapist perspective and recommendation for what's, best for them and safe. And there's a lot of communication that goes on behind scenes between social work and therapy and physicians and just everybody being on board. So it really is a collaborative process.
The next question, maybe just Amy, and we'll try to get to one more here before we reach the end of the segment. Do you deal anything with bodily fluids when you're working in occupational therapy or some of those elements, or do you not necessarily get into that? People are curious, Amy, if you want to kick that.
Yes, there is bodily fluids of every kind imaginable. So because we deal with ADLs, which are activities of daily living, we do showers, we do toileting, dressing, all of that. Which obviously has some bodily fluids. And then also with the pediatric clients that we see, you have all of those expected bodily fluids. Feeding is another one that we get into when it's not a swallow difficulty. So.
And something else on the outpatient side is I do a little bit of wound care. So that's another component, blood, taking out sutures and staples. So different type of bodily fluids, but still a bodily fluid.
Absolutely. Yeah. Well, that's great for folks to be able to keep in mind. Maybe another just pulse check question here. Do you guys do surgery?
You say surgery. Oh, no, it's a close collaboration process with the surgeon. It's typically like I'll have a patient come in, and I'll do an assessment. And then if something looks like it's outside the scope of what therapy can fix or help with, then I refer them to the orthopedic surgeon or their primary care physician, whoever they come from. I do superficial debridement of wounds, but nothing too deep or no surgery.
Right. Well, and our last question, are internships, are shadowing available in occupational therapy, whether that's at Rooks County or again with peers in other areas or in other environments? Is that something where, whether you're again traditional student or non-traditional, if someone wanted to shadow or look to try to see that more hands-on day in the life, with HIPAA and whatnot in mind, is that something where that is even an option in occupational therapy, Jesse?
Absolutely, yes. We frequently actually take undergraduate students from Fort Hays State. They'll send a handful of students over for either just a job shadowing experience or for credit towards one of their internship classes. And that is often a prerequisite for application to grad school is so many hours in different settings. And so it's nice to have that before also to just solidify, that that's the field that you'd like to go in. So